So it does look like we have Jeff Tomlin here with us. So thank you so much, Jeff, for joining us today. Jeff is the CEO of Evergreen, as you know, and we are so thrilled that he joined EvergreenHealth as CEO last year. Prior to that, he was a medical doctor at Evergreen, and we appreciate you taking the time out to speak to us today. Thank you. We know your schedule is incredibly busy. So whenever you are ready, Jeff, just give us the thumbs up, and we would love to start your presentation.
Yeah, thanks, Samantha. Kate, do you have anything to go over? Okay, great.
The invitation.
Yeah, well, great. You know, often I subscribe to Mark Twain. I think it was Mark Twain that said it's better to keep your mouth closed and let people think you're an idiot rather than open up and confirm it. So I found over the last 6 months since we've been exposed to this that we've been required to have a lot of interaction with the media and chances to share our story. So I am very grateful for the opportunity to share our story with you. I have an added guest with us here, Dr. Ettore Palazzo, who's to my left. And he is the Chief Medical Officer. I'll let him introduce himself here just a little bit. But as we thought about what we would talk to you about today, I thought our story is important, but I think for all of you, what we're seeing now, what perhaps the future holds, what about treatments, those kind of things. Dr. Palazzo and his hospitalist group, who have really been the frontline physicians, obviously the emergency department physicians, but the hospitalists and intensivists have been the frontline warriors working with the nurse and techs and other caregivers. But this is the group of docs that have really been there. So I think having Ettore here will be really helpful for everybody. So thanks for joining me, Ettore. Next slide, please. And by the way, Samantha, how much time would you like us to take?
You can have about 45 minutes, Jeff.
Oh, great. Okay, great. All right. So who's advancing for us? Is that?
Yeah. So Katie is going to share her screen here in just a second. For the presentation up and going.
Yeah, and I see a couple of Overlake guests there. So Tom DeBoard, Chief Operating Officer there at Overlake. Good to see you there, Tom.
Hey guys, good to see you. Looking forward to hearing from you today. And we, as I said earlier, we really appreciate our collaboration and partnership with you guys. It's been great.
Yeah, and a lot of the things that you'll hear from us, certainly Overlake has been involved with as well. And I can tell you that we work very closely with Overlake on a number of these issues. As we get deeper into the discussion, you'll see. Okay, next slide, please. All right, well, so that's me. I'm a local guy. I grew up here in Bothell, went away to school on the East Coast, had some time to pay back on the service, and then came back, went to medical school at the University of Washington, and did an anesthesia residency. And those things are all germane to, I think, my response as a leader in the organization. I've only been in this job for just about a year, although I've been here at Evergreen for 30 years, prior Chief Medical Officer. So know the community well, grateful to serve. And next slide, please. So this is what I did once upon a time, flew in these big formations, refueling pilot. I had a brief stint flying jets as well, but when people ask me what it was like to be a part of this response, next slide as well, these things that I did in the military really prepared me well for crisis management. So when you're doing simulation, for those of you that are pilots and you have simulations, they throw scenario after scenario and try to overload you, overwhelm you. They want to stress you, see how you do in stressful situations and what's your problem-solving skills. And both as a pilot, active duty officer, then I went into the Navy Reserve Medical Corps. I had the opportunity to go participate in crisis management exercises, war games, if you want to call them that, both at the Pacific Fleet, the European Command in Stuttgart, Germany, as well as NATO. And so I got to watch these very high-level military commands with 3- and 4-star admirals and generals, and watch how they would throw scenario after scenario at these different teams. And the key takeaways that I had from both flying and this reserve medical career were really your ability to respond depended on leadership and how well teams came together to problem solve, because so much of the crisis that you're confronting have unknowns, and you have to problem solve, and the team has to collaborate well to do that. Otherwise, you're not successful. And I got to see those kinds of things happen at a very high level, mostly in training environments, but learned a lot from having those opportunities. Next slide. So certainly one of my partners in crime here has been Dr. Palazzo. Dr. Palazzo, would you mind introducing yourself?
Sure. Good afternoon, everyone. So I'm Ettore Palazzo. I'm the Chief Medical and Quality Officer here at Evergreen. I moved into this role about a year ago when Dr. Tomlin transitioned from this current role as the CEO. I have been here at Evergreen for 17 years, trained at the University of Washington, and worked as a hospitalist, so a hospital-based physician. And I continue to get to see patients, but the administrative work in supporting the hospital in this role has been a great honor, and it's been very interesting to see in this pandemic the association of the frontline physicians and how they responded to this, and then being able to support them in this role, and then support the organization from an administrative standpoint and really interface with how we've had to deal with this.
Awesome. Next slide, please. All right, so we're going to tell you a little bit about what we experienced, our journey with it. Very important part of continuing care, essentially working alongside the virus, not only for healthcare, but things for you in the business community, resources to the community, and then community feedback, which has been very important to us. And then if we have time for questions, that'd be great. Next slide, please. All right, well, I got this from my adult children. For those of you Back to the Future fans, I think it's probably pretty appropriate, but a lot of, this has been an unusual year for a number of things. Next slide, please. So this is the Kirkland campus, and I just wanted to tell you a little bit about us because most people associate EvergreenHealth with this campus, but we're so much more. Next slide. So we have all these different services. We have a fairly robust medical group, over 300 providers, many clinics from Sammamish to Sultan to Mill Creek. We have one of the largest, if not the largest, in the Puget Sound area, home care, home hospice service. And so we tell you all that because even though the hospital was the first to experience the COVID virus, we really had to problem solve for the whole continuum of care. And many unique challenges, but really was all about problem solving for everywhere that we would touch a patient and their family. Next slide, please. So we are a public hospital district. Most people don't understand what that means. It is a geographic area, just like a fire water district. King County Public Hospital District 2. Our governing board is elected. These are our commissioners. And they take their jobs very seriously, as all boards do. But I think the fact that they designate where the levy funds go and how those things are spent from the taxpayers, there's about 20 cents on every $1,000 of assessed property value that people who live in our district contribute to us. I think people think it's a larger dollar amount than it is. It's probably 2 to 4% of our operating revenue. So it's a small part of that, but a very important part of what we owe back to the community. Next slide, please. So this is a picture just of some of the staff of our management team, and we've given a presentation to the State Hospital Association based on our experience, but these are the leaders that represent a continuum of care from home health to the clinics, and you can see Kay there. Ettore is just to my right as you see it, but one of the folks that has become very well known from our staff here is Dr. Francis Rito with the sort of red tie there and blue shirt. So I want to tell you briefly about Frank because he is an infectious disease doctor. He's been with us for, I think, just about as long as I've been here, almost 30 years at Evergreen. And just like as a young man, I had the military in my blood, Frank was working with the Public Health Service, and he became what is known as an Epidemic Intelligence Services Officer, or EIS. And I learned that that's kind of a special group. I think they have a special handshake, and they just kind of wink at each other when they get in the same room, and they kind of know where they've been, but they are. I'll give an example about Frank. Frank, a couple of years back, said, Jeff, I need a couple of months sabbatical, and it was a time where we really needed him. I said, Frank, I really need you in the clinic. What are you going to do? And he goes, well, Ebola is broken out in Africa. I got to go down there. And he's made several trips down there to work with CDC, World Health, and others. But it's just in his blood. They go to where the outbreaks and the fires are. They run to it. But Frank became quite the media star. You've probably seen him on PBS and CNN and others, because we'll have a lot more to tell you about his role in the story here. But just remember Frank as we move forward through. Next slide. Another couple of things about the hospital. For those of you that in the area in Kirkland, I think you can be proud of the safety quality work here. America's 100 Best Hospital for Health Grade, Leapfrog A. One of my favorites is the CMS. We were the first hospital in the state to get the CMS or Medicare Medicaid 5-star rating. We've kept it since the outset of that award. It's one of the more difficult ones. A bunch of Yale statisticians got together and came up with a way of grading hospital quality. But proud of it, but also know that we can do it better. And I think that's part of really the culture of the organization here, is that they know they can always do it better and not resting on laurels. Next slide, please. So we, as I mentioned, is a public hospital district, and our commitment to the community. We do our best to reach out, and a lot of different activities. Obviously, COVID has put a bit of a damper in some of the presence, but grateful for the opportunity to serve the community. Next slide. This is an example of some of the ways that we try to give back to the community in terms of these levy dollars and some of the things we do for charity. Just know that that really, being a public hospital district, I'll tell you more about that in terms of emergency preparedness, but it comes in many forms in terms of the give back. Next slide. All right, so this slide, one of the things that as a public hospital district, we felt that taxpayers felt like if there were disasters or emergencies that they would be looking for us to be able to respond and stand up all the services that are necessary in an event of a crisis. So we took that seriously 10 years ago. The Department of Homeland Security and FEMA set up what's called the Center for Domestic Preparedness in Anniston, Alabama. It's a old Army base. It's covered with, it's surrounded by tall fences and concertina wire because they train first responders with live agents and other things, as well as healthcare workers, in an all-hazards response to whatever crisis comes your way. It could be mass shootings, it could be chemical spills or pandemics, whatever it is. You get a couple days of didactics, and then you go through scenario after scenario, much the way I described my days with the military. Great training. We've had well over 200 individuals we've sent down there for the training. And so they come back, and this has really become part of our DNA. I think every healthcare organization has to stand up incident command systems, but we do it a drop out of a hat. If we have snow days and employees can't get back and forth, we stand up the incident command system. If our network goes down, we stand up the incident command system. And so we were used to doing it, and this training really had a very important part of how we responded. Next slide. We also are grateful to the people that came before us who gave us a facility where we had, I think we've counted at least 120 rooms that we could reverse to this concept of a negative pressure or reverse flow. If you think about a normal HVAC system, you push air, heat, and air conditioning out into the organization. But if you're going to have a pandemic and you have airborne pathogens, you're going to need to not do that. So you need to actually push them out of the organization instead of into it. So the ability to do that, the fact that the commissioners and previous leaders had looked at SARS-1 back in 2002 and 2003, the thoughts of Ebola and other things, that the ability to make a safe work environment facility. Next slide. And I would also say that we did a lot with just training our staff. I think, again, we put the PPE on annually, make sure people knew how to use it. And so as a part of how we responded, I would say 95% of it is how you prepared. And so we did have the FEMA training. We've set up the incident command system. Through Dr. Rito, Dr. Palazzo, and a lot of the great work there, we had a high consequence infectious disease pathogen team. They developed workflows as well as order sets and things in time of a crisis. And we had the facility. We participated in the Northwest Healthcare Response Network and all the exercises done there. And then some really rigorous infectious disease protocols. So this was our preparation. But you never know, even though you've done these things, how your team is going to respond. What's the culture of the team that you are going to bring to a crisis like this? And that I would say was perhaps the biggest thing you could not predict. Next slide. All right, so this is some of the pictures. You know, it seems like every time you put a camera on somebody in the midst of this thing that they would all smile. I was looking for some serious shots, but next slide. I think it's worthwhile to go back to the timeline. And Tori, maybe you can help me with some of this, but 6 months into this, it seems like pre and post worlds of the COVID virus, and think about how much we now know about the virus, even though there's so much we don't know about it. But recall, if you would, back to end of December, January, what was going on there. And Tori, would you mind maybe talking about January, what we were thinking, you and Frank in particular, since you're kind of our lead docs on what we were hearing in China and what we thought maybe here?
Sure, absolutely. Thank you, Jeff. Indeed, as the graph showed, and what folks might remember, the first cases in China being associated with the Hunan seafood market really came in late December. And you know, as information was coming out, we and Dr. Rito appreciated that this very well could be a challenge, but it just seemed so far away for us. That stated, it was interesting, if you map this out, several months before, the team here at Evergreen actually had stood up the high consequence infectious disease pathogen group, recognizing that the work that had gone into that here at Evergreen with policies, procedures, and such were really focused on Ebola. And I remind Dr. Rito about this quite often. At those discussions back in October, well before anything that was going on in China, he actually said, you know, I'm less worried about an Ebola coming to our shores and more about a respiratory pathogen that could stress the system, and are we ready? And so with that in mind and being able to understand what we could do from a negative airflow situation, what rooms were ready, what we would need to do to flip the switch, it was very fortuitous that several months before it came to us on February 28th, we knew that playbook. There wasn't a lot of extra work that needed to go to dust off policies and procedures because of that, including an assessment of what our PPE needs were. So I think it was amazing how quickly they were able to sequence this virus and get that out so we could start doing testing. And that led us into the scenario where certainly in January, the first case in the United States was not here at Evergreen, of course, it was up in Snohomish County at Providence and Everett. But when that happened, that really was the trigger for us here to say, okay, it is here now. It's only a matter of time before we would expect to see some sort of case, not knowing what ultimately would happen. But again, the graph here really puts in place how quickly things transpired. And then January, and then for us, February 28th, when we learned about our first two cases, which we can talk about.
Yeah, so Tori, when we had that case in Everett and Providence, were you thinking this was going to behave more like SARS-1? Were you thinking worldwide pandemic at that point, or did you thought maybe it's sporadic? What were you thinking, Frank?
Yeah, personally, we had lots of discussions about it, and the thought was not that this would be transpiring into a full worldwide pandemic. The thought that like SARS-1, where this would be a potentially challenging virus, novel, immune systems not being prepared for it, but based on prior experiences, it suggested this could be contained. And I think 2020 hindsight, it's easy to say, no, that couldn't be the case and was not the case, but we were expecting more of a SARS-1 type experience here.
Yeah, and there was a lot of questions, you know, is it an airborne virus? How lethal is it? What happens if it gets, so there were just a lot of questions, and yet we were kind of looking for things. So Just a few words about Dr. Rito looking at CDC and where he was. Next slide, please.
Right. So this is what transpired. Essentially, we knew that as cases were coming in, potential exposures either from travel from an area that was endemic, like China, or if there had been a known exposure, the CDC gave us guidance on those types of patients that could be tested. On February 27th, the CDC changed those testing guidelines, in particular saying that beyond just those two prior recommendations, if you have a patient in your hospital that has unexplained respiratory illness, without any other known exposure, it would be acceptable to start testing those types of patients. And that happened to be actually on February 28th, the first day that the state lab came online to be able to do COVID-19 testing, noting that prior to that, all test samples had to be sent to CDC in Atlanta. So we decided, and actually it was, I really credit the infection control team and Dr. Rito, they saw those new testing guideline changes right away. Immediately that night, we identified 2 patients that we did not have a good explanation for why they were so sick from a respiratory standpoint, and decided to test them, never expecting that they would come back positive. We saw this as an exercise, as how to fill out the forms, how to interface with the state lab, and just preparing for cases that we think would come. And when those 2 tests, in fact, I was working the night before seeing patients, when those 2 tests were sent off, we had no expectation that on the evening of February 28th that they would come back and be positive.
Right. I think he called instead of you sitting down, Ettore, because he was really didn't believe that those 2 tests that he sent both would come back positive, and they were critically ill, and unfortunately both expired, I believe, and we ended up being the first in the U.S. to experience a death with this. But this is the timeline, and so that evening, next slide, please. So that evening, all those things that we talked about preparing, once we knew it was in the facility, and the team brought in the incident command system, we began thinking about reversing airflow throughout the facility, so the engineers started to do that. We had to deploy the PPE. All those things kind of started happening concurrently. I like this slide because, remember, early days, think about what you see in this slide. For one thing, we don't allow more than 10 people in that room at any time now. We all have masks. And my favorite, though, is Dr. Rito standing up there with his hand on his chin. Don't touch your face, all those kinds of things. So we look very different now. We had as many as 20 to 30 people in that command system doing problem solving. And you can see a little bit of the gravity of it, but on the walls, we began putting paper everywhere to start doing problem solving, and we were well over 100 different either problems or policies that needed to be done. And recall, this is all new, and we were doing it on our own. As a part of that all-hazard response, one of the things FEMA teaches you is you can expect to do this on your own for 5 to 7 days, and don't expect either Homeland Security or FEMA to be there for that period of time, because if you have, as you've seen with Katrina and other essentially earthquakes and storms and things, that sometimes they can't get there. So we began doing that on our own, and we also went directly to the employees. So we all got a job to go out to talk to some place in the organization. Mine was OB, which was interesting. I got assigned OB, and I thought, well, I wonder how OB is going to respond to this. And so, would they be fearful? They traditionally are known for doing a lot with infectious disease other than prevention. And so when I went into the manager and talked with the team there, they said, rather than, fear for their own safety or such, they said to me, Jeff, well, what are you going to do if you have an expectant mother come in with a fever and they might have COVID? And I thought, I haven't had time to think about that, but I'm glad you brought it up. And sure enough, 48 hours later, we came in with a mom with a fever. And because they'd asked the question, because we'd heard that from the front line, we actually had a protocol in place in case that happened. So just the value of getting out and communicating with your front line and listening to them. Next slide, please. So, example, in home care, we had to start solving about exposures and what are we going to do, and just a reminder of all the things that needed to be solved for. Next slide. And getting that PPE out there, one of the learnings there was that we had practiced putting it on and taking it off, but we'd not practiced wearing it for extended lengths of time or cleaning it between multiple patients. And I think just as FEMA had said, we started getting stressed on day 4 or 5. If you look at that PPE on the woman on the right there, those little sort of vinyl or plexiglass, whatever those things are, those clear plastic visors, if you wipe those things down enough with bleach, they start to fog up. And furthermore, the inside of those pappers and cappers start to smell like chlorine. And on day 4 or 5, we rounded up on one of the floors with a number of patients, and the team was getting pretty stressed. They couldn't see through those things. It smelled like bleach, and furthermore, they had to go in and put it on, take it off, clean it off. The labor involved with it was really great. It stressed the team. I was getting a little worried that if we didn't get a delivery of PPE that we could be at the breaking point. And gratefully, I think on day 5, it magically kind of showed up, and I'd still like to figure out where it came from, but the team was much happier and much more capable of caring for the patients with the new delivery. They were very great, though. They were all brave and put that gear on and went in, again, not knowing how this virus was going to behave at the time. As an administrator, my biggest concern was we not only had 2 patients that passed quickly from the disease, but we had a number on the floor because of our proximity to the life care center. We had a number of patients that we soon discovered also had it, and we were treating them like they had the flu, and so doing the regular droplet precautions. I lost sleep a few nights wondering on day 5, 10, or 15 if we'd have our own outbreak in the hospital, because we really didn't know how the disease was going to spread. Gratefully, that didn't happen. Next slide. Okay, some of the media immediately, we knew that we'd be the focus of a lot of attention, so all these folks started to descend onto the campus. We had large antennas out on our parking lot, and Dr. Palazzo, Dr. Rito did the brunt of the early part of this. The communications team said, we decided that the best thing to do here in the early days were to get Drs. Palazzo and Rito downtown with the Department of Health to do the communication releases, because we were really concerned about making sure we'd had our staff and families and patients safe, that the PPE was being deployed, that our policies were going to work, and really in those first 48 to 72 hours, we needed to make sure that we had the thing under control. So I have to commend our communications team and how that handled. I think they did a really good job. Next slide. So part of that problem solving is that we had all these people at Life Care, we had our own employees, we had first responders who are now all exposed to this virus, and know that we got up to over 60 inpatients at one time. So a lot of people were exposed. We didn't know what that meant, and so we had to come up with a testing protocol, knowing that there was limited tests. And everybody in the Puget Sound was thinking, how am I going to get tested? So we had to kind of do this discreetly. And Liz Schaefer there, the lady with the ponytail and the mask, works in our registration. And she said, you know, Jeff, this is really more about how we register patients and get them in on appointments than it is even about the clinical part of just swabbing their noses. And so this is the bottom floor of a parking lot right next to us underneath on one of our medical office buildings. IT brought in all sorts of cables. And we developed the nation's first drive-through testing. Again, there was no script for this, and so we had to develop it. We got, at that point, we had 50 appointments within a certain period of time, and every one of those folks that had an appointment came through exactly on time, and I think most people didn't even know that was probably happening around us. But great problem solving on this one. Next slide. Again, this was early days, and so I'm social distancing. Before social distancing was cool, but I don't have my mask on. This is the team that was doing the swabs. I like this slide because the tall lady in the middle there is from public health. She was one of those EIS officers I was telling you about. She'd been working for several months, taking or receiving Americans coming back from China in California. So DOH, public health, CDC, everybody was working together with this, and they're members of all those teams, King County Public Health, and Evergreen working together. And we got a lot of great compliments from CDC on how well this the collaboration happened. She said it was one of the better episodes she'd seen with her experience of COVID to that point. Let's see, next slide. Okay, as I mentioned, the difficulty of all that, but it was a very stressful time, but couldn't be prouder of how courageous the team was in terms of making this happen. Next slide. The media again, it was fun with the media because I would say early on, half of the media wouldn't come onto the campus. So we did, it was early winter there, we were outside doing these outdoor interviews because people wouldn't come in. But once the media came in and looked at these individuals like these two men here, getting the gear on, going into care for them, it became very real. And I think it did change, I think, a lot of the media as they got to see what was actually happening. So very glad to those that were brave enough to come in and look at this with us. And I have to say I worried a little bit that we were protecting them too, because we didn't know exactly how this thing was going to happen either. Next slide. Big thanks to Congresswoman Susan Delbene, 1st District Congresswoman. She came to us in the first week, and so this was a press release. And with Dr. Vito there again on the right, you can see Dr. Palazzo, Mary Shepler, CNO. And the Congresswoman asked me, said, you know, what can we do to help you? And this is sort of an interesting response because we had some trouble getting deliveries. Just as a for instance, you know, the emergency department was ordering pizza because they were busy caring for all these patients, and the pizza person said on the other end, you know, we no longer deliver pizza to Evergreen Hospital. And we thought, well, that's not very kind. But then worse than that, we had some suppliers that you would recognize by name that said, you are no longer delivering to Evergreen Hospital. And remember, we were really the hospital dealing with this, and we're getting the reputation of being COVID General Hospital in those early days. And patients who were coming in with heart attacks or stroke were telling the medic drivers not to come to Evergreen because this is where the pandemic had broken out. It wasn't true, but we were having to overcome that a little bit. And so the neat thing about this visit with the Congresswoman is that once I sort of jokingly said, you know, help us with the pizza, the next day got a call from their office and they said, hey, Jeff, this is Congresswoman Delbene's office. Don't worry about your deliveries. That's been taken care of. And sure enough, pizza and supplies showed up. Excellent. Okay, Tori, why don't you talk a little bit about some of the many problem-solving things we had to do there.
Sure. So, you know, after we got through the first couple days of understanding what we needed to do to set up for negative airflow, transitioning over various parts of the hospital to negative airflow, using those original policies and procedures, and then going above and beyond, the engineers helped and worked on areas of the hospital that normally weren't set up to do that, but making that happen. That was all work in the first several days and then into the weeks. The drive-through testing was absolutely necessary to make sure that we had a safe way of testing our patients and staff that had been exposed, and Dr. Tomlin talked a bit about that. Clinic visits was very, very interesting, right? The challenge of making sure that we had a way of getting patients care that needed the care, but also the concern about not putting them in a situation where they would be exposed. And so this really, you know, enhanced and set up the virtual visit process that now so many organizations are doing. A lot of what we were moving towards anyways, just in rapid fashion. Elective surgeries, well before there was a mandate from the governor to cancel elective surgeries so that we would have appropriate PPE and space to take care of patients potentially, we saw a need here to adjust how we were doing surgery so that we were not bringing patients into areas that potentially would put them at higher risk. So we created a protocol. It was very interesting. We shared that with the CDC on day 3, thinking that maybe they had already something in place for something like this, and they did not. They liked what they saw. They took our notes back to Atlanta with them. And it did prove to be an important exercise in making sure that we set up our areas with appropriate staff and being able to have rooms available, including the ORs, if we needed to take care of patients there. The projections of the demand for surgical, or I should say for bed needs, based on what the COVID trajectory was, suggested that we could potentially need other areas. So canceling and adjusting elective surgeries well before it was a statewide mandate was part of our work here. The ED and the urgent cares, this surprised us a bit. I think folks have heard about the fact that ED volumes did go down, and there was I think a fear on the part of folks on coming to the hospital in the emergency room, and we worried, where were those heart attacks? Where were those folks that normally would come in, strokes and such, that would come to the ED that weren't coming in? So the campaigns that were part of the work here at Evergreen and then through the Washington State Hospital Association to let folks know that we're here to continue your care and we can do this safely based on the protocols that we've set up. And then other areas for outpatient services that fit along with that, mammography, our mammography coach being set up to be able to go out and do screening mammograms, and having the coach set up with UV lights inside and doing everything we need to do to make sure that those individuals receiving care were safe. And the diagnostic imaging and GI colonoscopy portions were very similar experiences.
Next slide, please.
So we knew right away we had to have a minute-by-minute assessment of what was going on in the hospital with regards to COVID. This is a screenshot of our COVID dashboard, which continues to this day. It gives us a clear understanding of how many patients we have, how many employees have been tested, where those patients are in the hospital, how many beds we have available. And we use this religiously at our incident command to know second by second what was going on. We continue to use that to this day. This is information that was really helpful for us and that we shared with Vice Admiral Bono, the individual appointed by the governor to assist with the COVID response here in Washington State. So showing the playbook, this was a key to us understanding where our patients were, what the trends were, and there's ability to drill down to look and see what the trends were, which was very helpful for us.
Next slide. So this has really been 3 phases early on. It was, the first contact, making sure you are communicating, you had PPE, modifying the facility. Then remember the whole concept of preparing for a surge, very important, because we were in this battle with Overlake and every state hospital. Do you have enough PPE? Do you have enough beds and ventilators? Do you have enough intensive care unit nurses? What happens if you get the crisis standards of care like in Italy and perhaps New York City? So we were dealing with all that. So there was a lot of important problem solving going on then. And then really the third phase was, what about reopening? So grateful that the surge didn't happen, but there was, we've talked about contact tracing and predictive modeling and the social distancing, all this thing in our lexicon. Next slide, please. So this predictive modeling was very important because we needed to know how much we were going to need of all those different supplies and what was going to happen to us. And Ettore would look at this every day. That curve, you can see how it tails off. We're experiencing something a little bit different, but all this was very important to us and certainly adjusted. We're grateful that the surge didn't happen, but more to say here, just the next slide. Go ahead. So some of the lessons learned early on, we had to really conserve that PPE, the tracking dashboard. We had to go to video conferencing. We had a number of, visitors were limited. We had a number of patients expiring from the disease, so that grieving process had to happen with our frontline staff, which was been difficult emotionally for everybody. And we worked with video conferencing in some of those situations. Supplies, communicating, and I think the single most important thing is being present. But we shared some of those with the State Hospital Association and our colleagues. Next slide. One of the things that happened early on was the governor called all of us as leaders in healthcare together on a phone call and asked us how we were working together regarding PPE and intensive care unit beds and ventilators. And it was pretty clear we were playing a game of individual game of survivor. We were all doing as much as we could to make sure we had those things, but there was no unified response. So that's when the governor brought in retired Admiral Raquel Bono. I actually met her back in Pacific Fleet days. She was the command surgeon back there, and so I'd known of her. but she came in and helped make this from an individual sport into a team sport. And now all of a sudden we had to play our cards. And so Overlake and Evergreen had to tell the rest of the state what they had for all those things. And we were some of the leaders. I think perhaps because we were first, we were very aggressive in getting all the supplies that we needed. Next slide. Tori, a couple words about the graph here. What happened to flattening the curve and the modeling?
Right. So that original modeling that we saw before really spoke to resource utilization. And so what was expected of hospitals as far as their ICU needs and that sort of thing. What you're seeing here is what the actual hospitalization counts look like. And while I would say that those previous modeling numbers still showed some accuracy as far as how much utilization was needed, you see that upward peak that happened right there in April, and then coming down, and then indeed, that correlated with all the mitigation strategies that were put forth here in the state, as far as closing things down, the stay home, stay healthy orders, these sorts of things. It's no surprise, those things don't make the virus go away. They prevent us from transmitting it to one another. And so as we started to open up again, we certainly saw and have seen some increase in case counts. This here is specifically for hospitalizations, and we did see a slow increase with a peak then again at late July. We were pleased to see some trailing off on the most recent data here in August. And it's just interesting to see what patients were most affected by this in the time frame. The higher percentage of hospitalizations back in April really spoke to a more elderly, higher risk population. And the case counts that have gone up more recently are related more to younger individuals that would be less likely to need hospital resources. And that speaks to some of the difference in the peaks of the curve for hospitalization.
Yeah. Next slide, please.
So, 21 weeks later, from our experience, looking at cumulative confirmed patient cases, you can see, what our numbers look like. 688 cases, that's out of 15,000. We have had 75 patient deaths, and I'll tell you, we remember every one of those patients and the challenges and their families had as we were working through that with them. The staff, amazing as they, in their career and all of our careers, experiencing a pandemic for the first time. And how the team has been able to come together to deal with this and to work with the families that have lost loved ones. We've been very, very focused on keeping our own employees safe as well. And as Dr. Tomlin mentioned, it was really unclear at first what the transmission was going to look like. Was the PPE going to work? We did transition from a type of airborne precaution to more of a droplet precaution based on the evidence that was provided to us as we move through this. And so we have had 76 employees test positive. Many of those cases were community exposure, meaning that there was no evidence through contact tracing that they had ever been exposed here in the hospital based on where they worked and what they were doing. We did have some examples of case clusters where employee to employee. This is before our universal masking, and it was a very, very good show for us that once we went to universal masking, the employee-to-employee transmission that was small but existed really disappeared. So it was an important a point for us to recognize how important the universal masking was.
Next slide. So I have to hand it to our crew. We've changed policies on almost all these things. At times it felt like daily, but just imagine, each day we come back with something new. Oh, we're masking, we're not masking. Who's getting tested, who's not, who can visit. So the team here has been very flexible, but it's just because we've had to learn as we go along. CDC was here on day 3. We thought the cavalry had arrived and that they would have all these things for us and they'd have a playbook. And as we rolled out some of our suggested policies, they, to a person, said, yeah, that looks really good. You guys need to try that. So it was pretty clear that CDC wasn't going to have the answers for us. And I think the flexibility of the staff and the continued problem solving has been just amazing to watch. Next slide. So today, these many months later, we have a census, I'd say it's probably 5 to 10 patients. We do keep, per the governor's order, 20% volume and the ability to switch in case we had another surge. We can change up to 120 of our beds should we need it. And more importantly, we've figured out how to take care of patients better in our ambulatory environments and on the in the hospital as well. Something we call continuum your care, because we really needed to let people know that you don't delay your care, particularly for things, acute things for heart attack and stroke, because you're going to cause more damage. But we could also do the preventive things that you need to do as well. So next slide, please. Next slide. Oh, that is it. Safety is always priority. It is our priority. So this is making sure that we have PPE. We take temperatures. You see this a lot of places, but we needed to change our waiting rooms, as a lot of your businesses have had to do. And so we felt that we can be able to share some of those things, although I know many of you are having to look at these things as well. It does decrease efficiency, but the public needed to know that we had their safety in mind. And, even to going out and cleaning things while the public's there, which you often don't do until night, but showing them your commitment to keeping them safe was critical to reopening and reopening well. Next slide. So I'm going to go to Dr. Palazzo on this, because I think this is where I think a lot of you might have questions about, what's Evergreen doing for treating people? What about all the therapies out there? What about the controversies? It seems like even this, there's questions about even the confluence of medicine and politics and there's so much swirl out there that Dr. Palazzo maybe kind of talked about what we've done internally with some of these things.
Right. So because this is a virus, we first look to, looking to the scientists looking at various antivirals that potentially would provide benefit. Many have heard about remdesivir. In China, the initial trials there did not suggest a benefit. Here, we were able to participate in the National Institutes of Health Act 1 trial that now is into Act 3, which we're participating as well. And some of our own data revealed that indeed remdesivir does show a shortened hospital stay for those with severe illness. And also, although not statistically significant, there was a decrease in mortality for that group. So additional work now that we're participating in, seeing how effective that remdesivir is, now that we combine it with other types of medications. We know that one of the biggest challenges when people get very sick from this disease is not necessarily from the virus itself, it's from our own immune system that is over-regulated and thus causing really robust inflammation in the body. And that's leading to that inflammation in the lungs, requiring the ventilators for prolonged periods of time, even as the viral levels go down, with or without remdesivir. So the second portion of some of the therapies that we're looking at are immune modulators. How can we modulate that immune response? Noting that it's there for a reason. We want the immune system to fight off the virus, but not get overactive. So a combination of an antiviral medicine like remdesivir, and then in some combination with a timing that needs to be specified by the studies to say, does an immune modulating medicine help with that? And that's actually what the Act 3 trial that we're doing now here at Evergreen is looking at remdesivir in combination with something called interferon as well. So many other options that have been looked at, the hydroxychloroquine, which many have heard about, robust randomized controlled trials, which is what we really need in science to tell us if they work or not, have not been done to the extent that I think can answer this question. The limited studies that we have so far do not suggest that is overly helpful. Various vitamin supplements, zinc, vitamin C, vitamin D, we do not have any robust studies there either. There's some speculation and some small case control studies that have led to some suggestions for, I think, good, bigger trials that would help us answer that. We're even looked at plasma. If you've been infected before and you've developed your own antibodies, can we give the plasma from someone previously infected to an individual and see if that helps? And again, you see the little note there, need data, and right now we don't know for sure how beneficial this is, and the studies are ongoing. We're not involved directly here at Evergreen with any of the plasma studies, but we have, under compassionate use, provided plasma to one individual that we thought would be helpful.
Next slide. A lot of hope for vaccines, obviously, and this is an example of all the different methodologies. Quite a rush to try to find one, obviously. Next slide. And yet there's so many questions about vaccinations because, you know, how will the antibodies respond? Will you have lifelong immunity? Does the immunity last for, you know, a few months, perhaps like a common cold? There's just a lot of things we don't know about it, but certainly our hope rests on that as well as potential therapies. Next slide. And I show you this slide because the impact to all of us, and certainly you in small businesses, us as a larger organization, but there are a few service lines that actually generate a revenue for us in healthcare, and a lot of what we do is at a loss. But we just show you this in terms of what happened to surgery and what that meant to us, and certainly the loss in revenue was very extreme. Next slide. So as of today, we are $42 million off of budget, but gratefully through the CARES Act, hotspot funding, and a number of other things, we did receive $40 million from the government. So we're just $2 million off of our 2020 budget today. And so couldn't be more grateful for that, but you could imagine what it would mean if we hadn't had help from the government. Knowing that just the stress that you have all had, I know that there's some PPP that hasn't happened, particularly for the chamber, and Samantha has outlined that, but the significant financial struggles has hit everybody. Next slide. And I do see a lot of the questions. Hopefully we can, maybe Samantha can get those questions if you can tabulate them later. Big part of all of what we need to do is communicate, keeping the communities informed. Again, our communications marketing department has done a great job of just really doing their best to over-communicate. Next slide. And I see we're getting towards time here, so we're close to winding up, hopefully to get to your questions. But certainly crisis can lead to change, and this is examples of things that have happened previously. But how does our world look? Next slide. Virtual visits. We could not get payers to pay the healthcare organization to do things virtually for the longest time. As soon as the virus hit, then all of a sudden that opened up, and grateful for that because I think that virtual visits are now here to stay. They'll be an important part of the care continuum used appropriately. That's just one example of, I think, of how healthcare will be permanently changed. Next slide. Just a huge shout out to the community for all the great things they've done for us. I think over 20,000 meals showed up. The same emergency department that couldn't get pizza in the early days started saying, if the community continues to be this generous, we're going to need bigger scrubs for everybody. So really some great outpouring of support, not only in cards and food, but also finances as well. We got some very generous donations from the community. Next slide. Just again, the thank yous. Next slide. So thanks to the team here. It was very much a dedicated effort. As I said at the beginning, you didn't know how the culture was going to respond. The culture really, the team really showed up, did a great job, thought about their own, I think, vulnerability, but went in and did their work. It was amazing to watch. Tori, any other concluding comments?
Yeah, I would just say, I've said this before in a couple different venues, there's only one word for me to describe the response of the team here in the early days and continuing on now, and that's humbling. These are physicians and nurses and staff that I've worked with for 17 years, and seeing them all come together for a common goal really is, it helps me remember why I went into the business of healthcare, and certainly why I came to Evergreen, and that is our sole mission is to take care of patients, and right next to that is take care of one another as we do that work, and that has been exemplified through this whole experience.
So next slide. So we have, and go ahead, next slide, please. We have a number of slides on resources for the community. We can certainly talk about those and show you, but since we're at time here, Samantha, I thought we'd take some of those good questions I saw coming along. Is there a way for you to, or can we look at those? There we go. Let's start with this one. How many COVID patients could we handle at one time? It's a great question. It talks about our surge capacity, and I would say as a tee up to that is that we did not get overwhelmed. We're grateful that I think Dr. Rito, Dr. Palazzo finding this in the Life Care Center early on was a blessing in many ways. It's a very contagious disease, and so, gosh, a good 80 or 90 of their census of 120 got the disease, and we could have been overwhelmed, but I think it was contained there pretty well in the community. The community shut down in terms of distancing and a lot of things that helped us not get overwhelmed. So grateful that didn't happen. But Ettore, thoughts on how far we could go for surge?
Sure. So at one point we were set up to have up to 90 beds at the moment to have a negative airflow, and with the capability to go even beyond, potentially up to 120. I think we said our most that we had at one time was in the 60s. So that's where we were with the work of the engineers in identifying areas of the hospital that could be converted to negative airflow, which was a really key component, an important point for safety for the staff taking care of the patients.
Yeah, great question there on the politicization. Ettore and I have talked a lot about the politicization piece of this. I think when politicians get out in front of the people, the researchers, the scientists that are doing either the vaccination work or the studies on the medicines, people have to know that the amount of trials and testing that goes on in this, in some cases can take years to get to the bottom line. So it's not helpful when people come out and say that, you know, this thing is proven successful and then everybody buys the stock, and it just simply, people have to be patient. And yet I understand the desire to get to either a vaccine or a drug that's going to help us quickly, but these things take time. If some major prove to be highly efficacious, they will unblind studies and go to those. I mean, we've seen that happen in the past. So, Ettore, in regards to treatments, what would you say about those things?
Yeah, so it's tough. It's tough looking through, all of that to come up with a reasonable response as the physician and staff trying to do our best and apply this to our patients. And what tenets we use here at Evergreen and with the entire medical staff is we go back to the basics. You know, what did we learn when we look at the therapies and how they're proven or disproven to work? Look at the study methods, look at the types of studies, and then come to a decision at the individual level if we're going to proceed. And that's how we've approached it here, knowing that there's been a lot of extra noise on the issues that Dr. Tomlin described. So whether it's a CDC recommendation, our own Department of Health, we look at what the science is behind it and then help us inform where we go from there.
And a single study, people need to know that when a single study goes into a medical journal as such, we read that with anticipation, but we also wait for the rest of the studies to come along and either affirm or refute that study. So, yeah. So we don't hang our hat on any single study. I just think people need to know that there needs to be some patience around this. Just think how many years it took to get good antivirals for HIV, for instance. Let's see, next question, the outcome on the plasma case, compassionate use plasma.
Yeah, I think probably just for HIPAA purposes and beyond going too detailed or granular into patient details, I can't really expound much more on that, but I can say that there's been additional additional experience here in the region that has been yet to be consolidated to tell us ultimately what the outcomes will be. But we do look at any option out there when we have patients that have already used everything that we have available, and we look to the CDC, the FDA to see what emergency use or compassionate use options there are. So we have every ability to try and help those patients when they're extremely sick.
Another non-controversial, antibody testing.
Antibody testing, we have spent a lot of time talking about this and also looking at the data here. The question specifically is, are there any benefits in getting the antibody test if you feel that you've had COVID? And for us, the challenge is, what will we do with that information? If you've had an antibody response and we believe that the antibody test is accurate, right now we don't know if those antibodies are protective or not. So if you were to have the test and have an antibody analysis that suggests that maybe you were exposed, I, as a physician, can't tell you if it's safe for you to be exposed to someone else because you're protected now, or if it's safe not to wear a mask because you've had the antibody before. So it makes it really challenging for us to give advice on that information until, you're kind of hearing a common theme here, we have the data back to tell us that an antibody response from having COVID before is protective. We are learning much more about antibody testing in conjunction with what they're doing with the vaccine work, which requires an antibody response analysis. So at this time at Evergreen, we are not recommending individual antibody tests because it's very, very challenging to give any guidance on the results of that.
Mayor Sweet, thanks for your kind comments, and thanks for your leadership. Got to see a little video of us donning our masks, so that was fun, but very grateful for Kirkland and really the response, the first responders and everybody involved early on with this, very brave people. As Samantha says, geriatric practices, offsite visits, great, you're pointing towards the importance of protecting that vulnerable population. And frankly, as we open up and do more and consider schools and things, the thing that we've shown that will overwhelm healthcare's ability to respond is that vulnerable population. If it gets into our skilled nursing facilities and senior facilities, those patients come in and can stay here 3 to 5 weeks and on ventilators for weeks at a time. Mostly young people don't have that, so we have to do everything we can to protect the vulnerable. The move towards off visits in general, certainly telehealth in that population is a great way to do that, and everything we can do to keep them safe is very important. We'll work towards that. Staff deaths. Sadly, we lost a very beloved male intensive care unit nurse. The effect of that was pretty difficult, and Ettore knew him well from working with him in the intensive care unit. It was almost like your first combat casualty. I think it had a big effect on us. Anything to say about Ettore?
Yeah, I knew him well, had worked with him, and I'll tell you the staff, we think about him every day, and it also has helped fortify our mission to take care of everyone who comes through the door, and there's not a day that in a minute really for me that goes by that we don't think about it.
Yeah. Percentage of employees that did they lose due to fear of COVID? That's a great question. I think that's the first time I've had this one. Human nature is what it is. There were some that just ran to this thing, and then there was a small percentage, and it was a small percentage, where fear really kind of started to overwhelm them. And so that was an important test of leadership there. Interestingly, it was a lot of the individuals who weren't on the front lines clinically. I think that was an interesting study in human age. With the clinical people, because they'd been trained in biologic diseases and how to protect themselves, it was a lot about the ancillary staff, in particular, a very critical team of the environmental services who had to go into these rooms and clean up and sterilize those, procedural rooms and things. We really had to reassure them. Even IT people had great fear of coming on the campus. So a lot of communication to them about how to keep themselves safe, how we plan to keep themselves safe. But overall, I don't think we lost a lot of people just said, I'm not coming to work anymore. But a lot of challenging leadership issues there, but a great question. Avoid indoor settings, eating inside or outside, Tori?
Yeah, on this one, we're definitely looking to the CDC on what we're doing here to inform us on those same things. And we do know that if you're outside and there's great air exchange, the risk is much lower. So when you're inside, and most rooms aren't set up for negative airflow that really reduce that risk, we know that the key here is making sure that you remain 6 feet apart and that you have a mask on when you're in those scenarios. And what the CDC has told us is, if you're within 6 feet of someone for more than 15 minutes at a time without both of you being masked, that's a higher risk scenario. So if you can set up your situations when you're indoors, especially when you're obviously not with other family members. And the restaurant situation is a good example of that. And I believe the statewide mandate is that for eating indoors, that is allowed when you're without masks if you're with other family members. So the key there indoors is if you're with folks that you're not normally with, family and such, try and maintain that distance of 6 feet. Both of the individuals in proximity wearing masks really puts that at a low risk exposure situation.
So Samantha, I kind of see we're at time here. You know, this was Evergreen's story. I see Tom there from Overlake. You know, they experienced this as well, and they would have their own story about how they responded. I think people on the east side can be proud of how we came together in terms of some of the things that we did to share resources and such. Very glad to answer any more questions you would have, but really grateful for the opportunity to share our story. And if you have further questions about any of these things, we'd be very glad to answer them or help you in the future. Samantha?
All right. Thanks to the both of you for this really amazing presentation. It's wonderful to see all of the things that Evergreen has done and overcome during this. I mean, boy, there was no script, just as you said. So thank you for all of your care for the community. If anyone has any questions, you can send them to me, and I will get them to the team at Evergreen. So thank you so much for joining us. Thank you to our presenters today. We really appreciate it, and everybody stay healthy.
Thanks, Samantha.
Thank you.